Good day everyone, I'm Christina Sguerra from BSN2C and I am going to recite the procedures in umbilical catheterization. For the assessment, a timeout should be performed with particular attention to ensure that the correct patient is identified and to assess for any contraindications for the procedure. The procedure should take place inside a radiant warmer to avoid environmental exposure to the infant. And for planning, equipment as listed below should be obtained and inspected. Appropriate log work, if available, requires review. Written consent is necessary from the parent or guardian of the neonate after discussion of risk, benefits, and alternative of this procedure if not doing the procedure emergently. And then flush the catheter with heparinized saline to ensure that there is no air present in the catheter and to prevent clotting. Attach three-way stopcock into the catheter. And then for the equipment, first is the radiant warmer, sterile gown, sterile cap, mask and gloves, sterile drapes, umbilical tape, scissors, scalpel, bactericidal solution, iris forceps, non-tooth forceps, umbilical vein catheter, three-way stopcock, IV tubing, 3-0 silk suture, needle driver, sterile saline solution, and catheter size. For preterm, less than 1,500 grams, catheter size is 3.5 French. For full term, the more than 1,500 grams and the catheter size is 5 French. For the implementation, first is put sterile attire, and then next is the umbilical stamp should undergo preparation with bactericidal solution and umbilical tape placed at the junction of the skin and umbilical stamp. Drape the procedural field with sterile drapes. Grasp the umbilical stamp with non-tooth forceps and apply upward traction to straighten the umbilical stamp. Take a scalpel and make a transverse cut completely through the umbilical stamp 1 to 2 centimeters from the skin to expose the non-dried umbilical cord to aid in anatomical identification and cannulation of the umbilical vein. Identify the two umbilical arteries by their thicker walls and the umbilical vein by its position at 12 o'clock and its larger thin-walled appearance. And then umbilical tape. Grasp the umbilical vein catheter using an iris forceps. Gently introduce the catheter into the umbilical vein. If the condition meets resistance, send the umbilical tape and attempt to advance the catheter again with gentle and to clear the thrombus present in the If significant resistance is still present, abandon the procedure and seek an alternative method of intravenous access. If the line placement is for emergency access, advance the catheter 1 to 2 cm past the point of initial blood return in the catheter, which is usually 4 to 5 cm in full term. If the line placement is for more long-term access, the line should be advanced into the inferior vena cava just beneath the right atrium, which is usually 10 to 12 cm in a full-term neonate. Secure the catheter using suture in the cord. After securing the catheter, use a tape to create tape bridge between the abdomen and the catheter for extra protection against displacement. And lastly, use transparent dressing into the umbilical stamp and umbilical venous catheter.